Welcome to Healthcare Heroes, a podcast powered by NPHub.com.
We created this podcast to highlight the incredible, hard-working heroes inside healthcare.
The entrepreneurs, advocates,
and providers that are saving lives and improving their communities
one day at a time.
These are their stories.
All right, I think we're live. I think it's happening.
That looks like it.
Carolyn, I am so excited for this episode. I think I'm actually a little nervous for this episode, to be honest with you. And I'll share with
the people.
At least you know. So, Carolyn, I think just to start off to the NPHub podcast, why don't you take a minute to introduce yourself to the podcast and kind of share who you are? Well, also
Sure.
test for audio.
Yeah, so thanks for having me. So I'm a geriatric nurse practitioner. I generally just introduce myself first and foremost with that. I am an associate dean and professor at Emory at the School of Nursing. I'm based in the university, and I have some academic responsibilities there around our students and instructors and faculty when they engage with our clinical practices and clinical sites. And then I have a clinical practice. I'm the director and co-founder of a practice called Integrated Memory Care, which is a comprehensive primary care for people who have a dementia diagnosis.
What do you like better?
I think it's no secret that my favorite thing to do is to both see patients and operate that clinic. Well, and actually it's not even, now it's a whole program. That is, I think, this notion of, and what we have, we'll talk about it a little bit more, but it's a new model of care. It doesn't exist anywhere else, where we've placed primary care and dementia care in this one location and created what we think is just absolutely best care possible. I could spend all of my time and energy and attention focused on that. I just think it's, given my experience and background, all that stuff, this is like the thing I'm uniquely placed on this earth to do.
Wow. I think that there's so much there. There's so much there. I think before jumping into the clinic, because I know that's, I think, what is the most unique topic of today's conversation, really talking about how that clinic came about, how you guys are providing dementia care. Let's talk about finding that unique thing that you love to do. How did you come across that? Because I think there's so many nurse practitioners out there that haven't figured that part out yet. And honestly, there's a lot of people out there who haven't figured that part out yet.
Well, right, and I know, I think the question that comes up a lot when people are thinking about what is my thing, is that they sort of feel like it has to be like a destination. You know, what do I want to be when I grow up? I'm trying to figure out what I want to be when I grow up. Like, it's this thing. That's a little dangerous. It's overwhelming. You really struggles with any perfectionist tendencies you have when you frame it that way. But you start to think about what might be my next thing. And that's sort of the reality. We're always sort of going from one thing to the next thing, and that sort of builds on what we've done before often. Either it builds on a relationship, or it builds on a role or responsibility you've had. The thing that I hear that makes me a little nervous in nursing, that I got in terms of advice, unsolicited advice, while I was early in my career, were things about concerns about being too narrow. So I said, I'm, first and foremost, I'm a geriatric, technically gerontological is the term, nurse practitioner. So that's a rare type, that's a rare breed. Back when that was a certification option, only 3% of all nurse practitioners were certified in gerontology. And so people would say, don't you feel like you're going to narrow yourself too much? I mean, last I checked, there's no shortage of older adults. So no, I don't feel like that was very narrowing, but people would kind of they want to go the most broad when in fact you end up so undifferentiated that it actually creates so much more effort on your part to then find the thing. So I did gerontology as my master's degree. That was my first certification as an NP. And honestly, I was a little overwhelmed with all of the options in geriatrics and gerontology. I loved wound clinic. I thought that was really fascinating. I liked continence clinic. There are some pros about working in skilled nursing in terms of flexibility and autonomy and some leadership with nursing staff. I liked primary care. I really thought I would do house calls. Palliative care has always been an interest, and I've actually gotten more interested and more educated in that over time. And that's just in what is the quote unquote narrow field of geriatrics and gerontology. So I'm glad I ignored that particular set of advice to be too narrow, because that's really how I've gotten to the populations I'm interested in, the settings I'm interested in, and I got to be really creative there.
It's so interesting you say that, because in the like paralleling that in the tech space or even in like the business space, people love the more niche you get. It's actually more of a negative to start a company or to be in a business where you are sort of like doing everything. You know, you want to do like the one thing well. And even in like, even at NPHub, right? Like it's like we have to do the one thing we do really well before we try to do like 7 different things, right? Because then you just become like average at everything. So that's interesting to hear that even inside of the quote unquote narrow space that you went into, there was like 11 options for you.
Right.
Okay, that makes sense. So,
and out of all of those, I chose education.
Yeah, I know. Yeah, that was the other one. Okay. Well, so didn't you choose? So it's interesting you say education and not like on the dementia side, right?
Yeah, well, no, so my first thing that I ended up doing, and this was sort of life circumstance, is that I started as a clinical instructor at the School of Nursing. I had a new baby, and I had a faculty mentor at the time who said, you know, it would be great to have a young person who has energy and excitement about geriatrics. It would draw people, I think, to the field a little bit more, because geriatrics is something people find after they have a little life experience and go, oh, actually, this is where it's at. I didn't think this is where it's at, but now I figured it out, right? So, you know, that was my face. And I was pretty young doing that MSN. And so she thought, well, that would be great to be a clinical instructor on the unit. And the unit was a long-term acute care. So, and those were not as common as, and, you know, this is 20 years ago. So the structures have changed. But so this mix of sort of long-term care where I was comfortable, and it was in a geriatric hospital. So obviously my target population. And, you know, these patients had ventilators, tracheotomies, PEG tubes, maybe a PICC line. So I had been an ICU nurse. So very comfortable with those kinds of things. And now only in my population. So that was the first thing that I ended up doing. And then as it turns out, having that home base in education gave me all the flexibility I needed to have so many different practice opportunities and different partners. And, you know, I've been at the same institution for 20 years and changed jobs every 4 years.
Wow.
So it's still worked out really well.
Okay, so the one thing though that seems really consistent is the love for what you're doing in like with your dementia clinic. And I think like what was, well, first of all, staggering for me to kind of hear about, and from our first conversation, but then also just looking online, is you told me that there's only 1 of 4 of these sort of clinics in the United States.
So this is the only one like it in the U.S.
That's so I think everyone wants to hear about it because we're sort of hyping it up. But the other thing is that's mind-boggling. How is that possible?
Well, I think so. When we get compared with other models right now, other sort of new models in the dementia space, the closest thing to us, and it's much more common, not common enough, but much more common, are memory care clinics. So specializing in memory care, many times this is where people can go get an evaluation because they're concerned about thinking changes, not just memory. And they want an evaluation, they want a diagnosis, what is it that we're facing? And then most of them, not all, will also then do ongoing follow-ups. They might check in and they're a consultant. And sometimes they live in geriatrics, sometimes they live in geriatric psychiatry, and sometimes, and even more increasingly, they're in neurology departments. So that model clearly meets a population need, no question. For us at Emory, myself and a colleague, we were sort of living between 2 groups, between geriatric primary care and the specialized cognitive neurology practice. And myself and another advanced practice nurse, we're kind of looking at it going, but from the patient's perspective, does this meet their need? So we engaged patients, but actually in this space, more caregivers who were able to, from their perspective, talk about what they really needed. So what do you really need in your healthcare services when you have a dementia diagnosis or a concern for dementia diagnosis? And we built it around what they wanted, as opposed to looking at the infrastructure of divisions and departments and figuring out which one it belongs in. And then we thought, we'll just figure out any sort of turf wars, or not wars, turf battles, but any of that kind of weirdness.
I like turf wars
on the back end that we've got to figure out about, like, who owns what. That's our problem as a health system. That should not be the patient and caregiver's problem. So I think that's why that we started there. We went from the patient perspective and built in that direction.
Which, I mean, I think most would argue, or a lot of people would argue, that's what's sort of maybe missing in healthcare at the moment, right?
Yeah, agreed.
So let's talk about, like, how it's fragmented and then what you guys have done. What does the traditional model look like versus what you guys have built?
Yep. So your traditional model is you have your primary care. Hopefully you have a good primary care who's in your life and you're seeing them on a regular basis. Maybe you've known them for years. Mm-hmm. Many times that's where memory concerns are first discussed. And maybe they're doing, the uptake is not that high, but let's say they're doing things like annual wellness visits, or when somebody presents to them with a concern, a change in behavior, a change in their ability for self-care. Many, like, short-term memory loss comes up. People say, I'm concerned about this. We like to assume people don't have any awareness about their memory changes specifically. In fact, many people do. And and many of those people bring that to primary care for a concern. So hopefully some degree of an evaluation happens, and they may say, you know what, I agree, there might be some issues here. I'm going to refer you over to the specialist in memory care. So then that person goes to memory care. That's where they get maybe a more formal diagnosis, and someone can say to them, this is in fact, Alzheimer's disease, late onset, and it's early stage or it's moderate stage. And then they continue their relationship with primary care, and then maybe memory care will see them every 6 months, maybe once a year, depending on their capacity, because memory care clinics get overwhelmed pretty quickly. And when they follow up, they're focused on, okay, what's your thinking now? What's your memory now? What are your behavioral symptoms? Are we prescribing appropriately for cognitive and behavioral psychiatric symptoms? All that's good. So let's say, though, one of your other conditions is type 2 diabetes. And when your blood sugar is running a little high, you get even more brain fog. We all get brain fog when our blood glucose is off. So, but if you have underlying Alzheimer's disease, your brain fog might be really more getting up at night, exit seeking, potentially a fixed delusion that you believe someone's coming into your home. Okay, so that's actually a symptom of your diabetes. So but many times you call, right, the neurologist. So are we going to prescribe something to treat this? Are we going to identify that this is actually from your other chronic condition? Those two things, you cannot treat them in isolation. And so, in the case where someone has potentially an infection and they have dementia, that sort of delirium, we consider a medical emergency. But extra confusion in someone with dementia is not necessarily seen as a medical emergency in a typical primary care setting. And primary care is where you're going to have your same-day appointments and urgent needs, not over in your neurology clinic or your memory care clinic that, typically sees. So, like, we're checking in, right? We're checking in, things are to see where things are. It's not a same day, same week kind of access.
Even though what you just said a second ago is the exact opposite, right? So it's considered to be urgent in that case, but it's not considered to be urgent in the primary care space. So they're not going to want to see you, or they'll schedule you out.
Right. Oh. So, our practitioners in our model, partly it's the model and it's the people in it, right? So the nurse practitioners in our model are dementia care specialists. So they recognize symptoms that are red flags in a dementia patient that other practitioners might not recognize as a red flag. So that's one of those really helpful things. The second thing that really misses the mark on the traditional model is that so many times caregivers, care partners, the person who is your informant giving you a more detailed, accurate history of present illness, those people are left out of typical primary care visits. So you cannot, first of all, gather information about the history of illness, right? What's been going on, what's the symptom history without them. Once this person has a diagnosis, we have a known cognitive impairment. So that means your diagnosis will be off if you don't engage them. And if you have expectation of a care plan or a treatment plan actually being implemented, you're going to need that care partner's help to actually execute a change in prescribing or implementing sleep hygiene or whatever it is that you're about to do. You're going to need the care partner to do it. And so in a model like ours, we think of that care partner as part of the team. So it's your provider, patient, care partner. And many times in the traditional model, people leave that care partner out. They leave them in the waiting room. Before COVID, people cited it as HIPAA concerns. And then during COVID, I think it became even more easy to leave them out because of concerns about having too many people in the room. When in fact, if you see them as a core part of your practice, you find ways to make it happen.
That's interesting. So, and this is going to sound pretty rudimentary, but like, couldn't we just like issue out like a PSA if it okay, hey, like, if you have a dementia patient, primary care providers, this is what you should do. Yeah. Is that not how things work?
I mean, there was some movement a couple years ago. There's actually a CARE Act that was passed, but not every state's implemented it. And that was for hospitalized people, not necessarily just with dementia, but just hospitalized patients that, we ask things like if you have a healthcare proxy or a power of attorney, right? Most people don't have that formal document, but there's also like, who needs to know where you are and what your discharge plan is? And so you are supposed to have that in your medical record. That is part of law now. And that was one sort of, at least let's get one piece of legislation in the most dangerous time. If you can imagine, I'll never forget, we were at clinic one day. One of our patient's daughters called. Her parent was in, I'm going to say, assisted living and was having a psychiatric issue. They had called EMS. So the ambulance comes out. They take them to the emergency department. Okay, that's fine. And then from the emergency department, they cleared them medically and said, this person needs an inpatient psychiatric stay. Transitioned them to a inpatient stay, would not tell the daughter where they had transferred her. So this daughter is like, my mother is in a psychiatric hospital. Daughter's out of state, by the way. I don't know where they've taken her. Can you help me find her?
Doesn't seem right.
I think the providers who were engaged in that were like, well, it's patient privacy. I can't confirm or deny like where this person is, because the daughter didn't have power of attorney documentation, which once somebody becomes has this dementia syndrome and progresses, they may not be in a place to complete those documents now. So we're not going to get documents like that. But in reality, I mean, just like, let's be real about this. Why do you need to engage a care partner? Because someone needs to know what the heck is going on.
Yeah, especially if there is cognitive decline, right? Like,
yes. Yes.
That makes, wow, okay.
Yeah.
Go on.
Well, I was just going to say, the other thing that I get into with folks is, and this is kind of like in other primary care practices when I'm speaking or teaching or consulting, people talk about like, well, this is a HIPAA violation to bring somebody else into the conversation. So I think one thing is, what are you doing in that conversation with that care partner? So most of what we need is, I need information from the care partner about the patient. HIPAA says you cannot give information about the patient to someone else who's not involved in their care. So there are a couple issues there. First of all, this person's involved in their care. So but this question of like, I can't bring them in, I can't gather information about my patient, that's not HIPAA. That's actually benefiting you. There are ways to bill for that time, by the way. You can build it in your workflow. So this, the other concern is, well, I'm very busy. How do we build that into a busy primary care practice, especially? You can actually schedule that time. It is billable, it's reimbursable. And then the last thing that we run into is this concern about documenting information about the care partner in the patient's medical record. And that one gets a little bit dicey and you kind of have to work through that a bit.
Okay. But if it's a matter of providing proper care if it's a matter of providing proper care versus providing sort of like care that won't be, I think you used the right word, but if they're not part of the the treatment protocol and it's not going to be followed, why even do it, if that makes sense? The absolute need for bringing in the care partner into the visit, really being able to rely on them for one advice, or not for feedback, but then also assistance with the treatment plan that the provider is sort of is recommending.
Exactly.
That being said, so that's what's happening right now, right? So basically, as I'm understanding it, it's a completely fragmented model, right? Where you sort of, yeah.
Right, so none of that care partner engagement happens in the typical model, right? It might happen in the neurology practice or the memory care clinic, but it definitely is. It's just not standard typical, right? I mean, and culturally, right? We're like, oh, you're autonomous. You come in, you do your own visit, and it's just not the way that we operate our standard practice. But the biggest thing is, so it's the back and forth between the two, the primary care and the specialist, trying to figure out who can address this problem best, and then leaving the care partner out of all of it.
So in your clinic, how do you deal with primary care issues that aren't related to dementia? Because wouldn't that be a gap?
Yeah, well, it would be. So our model is this. It is primary care, first and foremost, for people with a dementia diagnosis. So this is, uniquely, we happen to live in a neurology department at the moment, but we really could be in either one, neurology or primary care, because we've sort of said, well, we're going to make this structure work because we think it's the best thing to do for patients and families. So we are, everything from, I love metrics. So everything from how well we make sure our patients have their immunizations, how well we're doing things like depression screening, fall risk screening, annual wellness visits, management of their blood pressure at goal, getting their hemoglobin A1C at goal, all of those things happen in our practice. But we think that the fact that we are in the context of this dementia syndrome matters. And so I'm probably going to think about someone's screenings, how aggressively we're going to manage someone's hemoglobin A1C, understanding that this person is late moderate stage of dementia syndrome with a Lewy body underlying pathology. That changes how I'm going to, what treatment plan I'm going to choose, what our goals are. And so that context makes a difference of how I deliver primary care.
So with your clinic, if the metrics are supporting that you guys are doing a fantastic job,
Mm-hmm.
and why not, or what's the next step for you guys? How do you go, how do you really take this to, because I know if there's one right now that is doing it this way, right? And I think if I remember correctly, it's one of 4 that's like nurse designed, if I'm saying that accurate.
So there are the other, so we've gotten to a really interesting place, right? So we run what looks very much like a value-based payment type of model that would do really well because we focus on our outcomes. Mm-hmm. But we live in a fee-for-service space. So that's kind of an interesting thing. So we've had to, so our ability to go, okay, what are next steps is a little bit, that is predicated on having a full capacity and being sort of running at fully utilized, because we have to do all the things, right? We have to have the, patient outcomes that are strong. I generally like to outperform any other primary care practice in things like that, which I think is really exceptional given our patient population. Mm-hmm. We have superior patient and family experience scores. And then, and we do actually have a financially viable practice. We're talking about geriatric primary care. It's it's not your rainmaker from a budget perspective, but it does have to pay for itself.
Yeah.
So we were able to sort of do that and get ourselves at steady state. We are looking now at our outcomes, and I think it's important to me that we have some more data-based publications out into the world beyond we have some initial things like year one, first 100 patients, that kind of thing. And now we're like, okay, let's get the big group and we actually have a comparison group that we can look at. And then we've started to get some recognition. So we've gotten, we're named as a best practice exemplar by the Institute for Patient and Family Centered Care. And I think based on what I just said about care partners and engaging them and how important they are as part of the team, that should not be a surprise. That did not go missed. That did not go unnoticed by that group. We've been recognized as a NCQA patient-centered medical home for 6 years now. So since we opened. So in other states besides ours, that will actually have a financial implication. For us, it's just important to have national recognition that we're an advanced primary care model. And then most recently, we became a top tier, so that's level 2, age-friendly health system participant with Institute for Healthcare Improvement. So we're starting to get sort of this like recognition that yes, in fact, this model works, and it works in all the ways. So that's how we ended up in that report. So then we were highlighted in the Milken Institute's report in fall of 21. And that report was about comprehensive dementia care models. And the other models listed were either community-based, so they were not delivering primary care or any sort of health care. It was community-based services, very focused on care partners and getting home-based services. I mean, wonderful services in the community. And then 3 of us are health system-based. The other 2 are nurse staffed, often physician-led, or at least physicians sort of leading that model design, and they're not doing primary care. So they're the consultants who are coming in to consult and then make recommendations back to primary care. But that report was focused on creating alternative payment models for comprehensive dementia care practices, and so we're really eager to continue being part of that initiative. That special report is going to, meetings with legislators, ultimately aiming toward the Medicare Payment Advisory Committee to say, if a practice meets these kinds of criteria, if they offer these services and have these metrics or outcomes, they should actually be reimbursed differently than your usual standard primary care. So that's kind of exciting. That's a big piece for us. In the meantime, though, we're not sitting still. So we still have this single site in Atlanta. Mm-hmm. We have 2 areas of growth. So the first is at our single site, we are opening another new model that will be sort of an extension of what we have in clinic. So in clinic, that's the integrated memory care clinic, and we are opening integrated memory care in community. And in fact, we have a whole nother set of staff people to onboard and train and get ready to launch to begin enrolling patients in this program. And the first staff person started last week. So, and another one starts next week. So we're just about to start like the onboarding where it's about to really pick up. In that model, we do everything that we do in clinic, but we actually deliver that to you in your home if you're residing in one of our partnered senior living communities. We get to add other members of the team like occupational therapy, geriatric pharmacist, and then a whole new dementia care workforce called a dementia care assistant that does cognitive stimulation and companion types of things with our patients every week. So
Got it.
Yes.
So that it's almost kind of like, I don't want to say it's more like what's the word, like house call service. It's not that, but it is, basically going to long-term acute.
What we call clinic it's primary care plus. I would say this is probably house calls plus.
I actually kind of like that line. That's really smart. So obviously, I think the biggest thing, obviously we can all tell about your passion for this industry, for working with geriatric patients. What do you say to NPs that are I think the statistic isn't it 73% or 68% of all NPs are starting to be an FNP at the moment?
Oh, it's high. Yeah, it's pretty high.
It's staggeringly high, right? So basically what you have is everyone going into the FNP, right? Which is what we just talked about, which is a very general model, okay? Which we know can be dangerous in a lot of ways. And then obviously when you go into the job market, you and I both know a little bit about that, the whole concept of saturated markets and people can't always get a position out of school and all that. So how do you convince people, or not convince, wrong word. How do you maybe inspire people or light that spark that, hey, going into geriatrics is not just a lucrative, right? Because that's not necessarily the right word, but rewarding career. But also lucrative, sure. Lucrative. Yeah. Talk through it.
Yeah. So it is also lucrative, as it turns out. So if you look at, sort of top 5, top 10 salaries by NP certification or specialty, geriatrics has consistently been up there. Huge demand, right? And not a lot of supply. So that really does help us quite a bit. I think, though, one of the challenges, I think, with people, and I don't want to bash FNPs, right? Like, I'm married to one, right? I like him just fine. I mean, he's okay, I guess, whatever. But
I like him just fine. I like that. You got to keep that line.
Right. He hears that a lot. Are you choosing that because you don't want to make a decision, right? Is this a decision avoidance tactic? Is it fear-based? When you're making decisions about your life and they're based in fear as opposed to being based in your passion or based in the direction you want to go into, then you're always going to have an issue. And I hope people have realized by now, none of the nurse practitioner certification areas or population focus areas, to use the appropriate language, are universal. It doesn't exist, right? You cannot be an FNP and work in the neonatal ICU. You cannot be an FNP and work in critical care. And in markets like major metropolitan areas like Atlanta, like Chicago. I mean, these major markets, it is challenging to be a family nurse practitioner and work in a psychiatry specialty, or to work for a pediatric practice or gynecology practice, because they really want people who have depth, not breadth. Now, if you're passionate about family practice, if you really think like there's nothing that would be more meaningful to me than to be in a community health center, to do full scope, to, see, the whole family, like see the family, the children, the parents, the grandparents who may all even co-reside. If that's what you're passionate about, go for it. I think what comes out, though, when I'm interviewing a fair number of staff people, it's obvious where your passion is, or if you have one. And so, I think you sort of, it's not a bad idea to spend additional time getting clarity about that. It's not, I know shadowing was something that people talked about doing, like maybe you can shadow people. Shadowing can be challenging for privacy reasons and systems issues and all of that. I get that. Worth trying, though. But, you can also take someone to dinner and talk to them about what they did today. And have some idea of what lights that fire for you. And who knows where we're going to head with this workforce, right? So I have colleagues who are expert geriatric specialists now. They started as a family nurse practitioner. I want to say, though, they did not become expert geriatric specialists by just seeing a lot of old people clinically. They did continuing professional development. They took roles where they had mentoring and coaching, and they actually took board certification exams to demonstrate that expertise. So, you can do that. You can say, I'm just not sure. The things that I want to do, maybe I have a list of them, would all fall under that family NP umbrella. And I'm going to do some of those. And if I really feel strongly about oncology, for example, or palliative care, then I'm going to pursue that additional subspecialty certification. But just be prepared that there's more work to be done. It's not a matter of like, I did this and now I'm done and I can go work with any specialty or any practice. That's just not the case.
At some point, it sounds like what you're saying. At some point, you're going to have to figure out, you're going to have to say, what am I passionate about? And stop being broad. whether you do it at the up front before you go to back to graduate school, and you do the I would argue probably no more than maybe 15 to maybe 40, let's just say 25 hours of work, right? Of interviewing people or taking people networking with some mentors. Obviously shadowing in like you said can be challenging, especially when it comes down to healthcare. But you're going to have to do some of that work. Either it's up front or then it's on the back end, which is, after the fact. But then what you've done in that situation is you are now specialized in one thing. You have your F&P, and it becomes even harder and harder.
Yep. And I don't want to say like you have to be on fire for something. What do you like though? At least start there. And and then I think just keep in mind when you're interviewing people, when you're talking to people in practice now, some of the things you want to know is, if you were starting over, would you do the same pathway? I mean, if they love where they are now, that's great. But what would be the pathway that you would take knowing what you know now? Because, people like me, right? Like I straight out gerontology nurse practitioner, I knew that's what I wanted to do. That's not an option. So how would I get to where I am now, given the options that are available to people? Or, like we do have family NPs or adult NPs who have found themselves in critical care medicine or as intensivists, but that's not necessarily the way that you would want to start that now. So because of my university role, I've worked with a number of people who came out of an F&P program who ended up doing a postgraduate certificate to become an acute care NP later. That's okay. And I think hopefully that experience is a positive one. Nurses are supposed to be lifelong learners. That's what Florence Nightingale says. So that's great. I don't know if you want to pay thousands of dollars to do that, or work every single one of your off days as a student again later. That's kind of where you want to end up. Yeah.
And Carolyn, real quick, would you mind moving over just a smidge to the, right there, just so you can frame it better. Yeah, thank you. So I would say that you said something interesting, right? Which is find out what you like. And in my experience, sometimes people have a really big issue even being able to articulate that. So I think another question for the just something that I've always practiced, or sometimes I'll ask people on my team, for example, when asking about their career development, it's like, what do you hate doing? What don't you like? Because a lot of times you can start narrowing down. Hey, I don't like this. Okay, well, then that probably means I shouldn't be in, marketing. Okay, cool. So it's the same way in nursing, right?
Agreed. Well, and I think, as an NP, especially if you've been working as a nurse, so if you've come out of school and you've done that more traditional model, you were probably hired as a nurse resident, or even if they didn't have residencies, as an oriented nurse with like 100 people. I mean, there were a lot of new grads starting probably when you started. That's kind of how it works if you work for a hospital system. And so in that case, you're like, okay, let me choose my specialty on the floor. You figure out, which units have better or worse cultures, and maybe it's the specific shift on the unit, who you like working with on your shifts, all those sorts of things. When you're going to especially primary care, but honestly, any of these advanced practice specialties, the world gets really small. And so you start to get some clarity about culture that is a fit for you. That, like some people really like being in more of a relaxed space where everybody respects off hours work. And some people are like, no, I'm like always thinking about work. I don't mind, like, it doesn't bother me at all if we're emailing all weekend about something, or if somebody calls me after hours about one of my patients. So like things like that. I think you're right. I think thinking about like, what don't you want to do? That's clear. In some cases, you might want to think about where don't you want to live? What type of community, right? Because again, in these big metropolitan areas, things are fairly specialized. Even, like we've raised our kids in Atlanta. They've never done family practice for their primary care. It's always been a pediatrician and a pediatrics practice. That's not the case where I grew up. Where I grew up, you're much more likely to be in a family practice. And so, but this is the type of community I like living in. And so that would be helpful. I happen to be part of a board that also reviews and approves, administers people who want to commit to working in underserved areas, rural areas, those kinds of things. And as often as it comes up that people just don't want to be in that setting. And some people love being in that setting, right? But if you decide you don't, now you've got like financial implications too. So, so if you're thinking, I mean, and if you like doing like high level NICUs, those don't tend to be in the smaller communities. So you just kind of have to think a little bit about, if you have a thought about where you want to live, maybe geographically, and then just the type of community, just population density wise, that might be good to think through.
That's interesting. I think like keeping in line with this idea of figuring out what it is that you want to do, and knowing that sort of we're coming up on this on the hour in a bit, and I want to make sure we touch on a few different topics.
Okay.
Right now, if you go on CNN every single day, there is an article talking about nurses leaving the bedside in droves. It is. We had Ashley Blackman on the podcast a few weeks ago, and she was talking about it. You can't escape it right now. So you have these nurses leaving the bedside in droves, and I want to talk about why that's the case. But then I also want you to talk about, if it's okay, that a lot of these nurses now that are burned out, they're defaulting to going back to school.
Yep.
And I don't know if they're doing that deep analysis on what they want to do versus like, I know I don't want to be in this hospital anymore. Yeah. I know I don't want to be treated like cattle anymore.
Mm-hmm.
What recommendation do you have for the, I don't even know, the tens of thousands of nurses right now that are like, I'm tired of working at the bedside. I'm ready to leave. The money's not worth it. I want to go back to NP program. I want to get into NP program.
Right. So it's been interesting, even in the last month, thinking more about like the nursing workforce and how to even forecast what it will look like in another couple of years. How much this pandemic has may actually change the whole way that we staff and hire nurses. I think, I think that we have thought about that workforce because there are so many of them for so long. Again, when you hire people in large batches, we have some systems, not all, obviously, have a tendency to sort of think about them as sort of like a population that's fairly replaceable. You got a license and a pulse, like we're good, right? And really not invested in what it means to actually engage these individuals, these educated, professional healthcare clinicians. We do not think about them that way, right? We haven't. So I think, some of that's been brewing for a while. And then now, like these, you get to work and it's just everything is short and you don't have supplies and people are sick. And then you got families who are either, at minimum devastated and having limited access to their loved one. And at worst, aggressively coming at you over treatments that they believe should be helpful, that, like all the crazy stuff has like really come to a head. I'm also, by the way, reminded, I think we've been living through this pandemic for so long, it becomes easy to forget that not that long ago, 2020, we also had quite a bit of a racial awakening around the disparities in this country. That didn't go away. So that's still there, maybe as just a secondary undercurrent. And I can't ignore, we have more diversity among nurses than we used to. We need more. But for our nurses of color, they have been affected by this pandemic differently than white nurses. And so I think there's so much swirling. It's about work and it's about outside of work, and about being that primary caregiver and all the financial implications for your family overall, and making caregiving decisions at home for someone you're caring for, whether those are minors who are dependents or older adults who might be dependent on you for help. So all of those extra pressures, and people are like, I'm done. It's like the pot, like the pressure cooker, that my grandparents used to have, is like whistling, right? Like we're out.
Grandparents? I still have a pressure cooker.
Oh, sorry. No offense. I use an Instant Pot, man. Come on. You're cooking probably better food than I am. I think that's what we just revealed.
Go on.
Old school. So, to that end, yes, for a long time, it's not new, but I think even more so for people to say, okay, I don't want this. I don't want to be in this hospital. You know what? I'm going to go back to school. And I think going to school is a laudable thing, right? I never want to minimize or keep nurses from having additional education. You can get education in lots of ways. Universities are one of them. Also other certificates, professional development, and so forth. I'm always concerned, though, when you go to something, whether it's a new job or this new role where you're going to be preparing for that, through going back to graduate school, when you're getting away from something instead of going towards something. And the investment that you're making in graduate school in particular is a significant investment. It's an investment of your financial resources, but also your human resources. So your time, your attention, your efforts. And so you want to choose the right, what am I going to school for? Right? That's really helpful. That actually also helps keep you, keep your chin up while you're going through that experience, because, school's going to change you. It's going to grow you. It's going to develop you. There are growing pains with that. So you want to be going towards something that is meaningful to you. I also, though, again, back to where we started, which is I run this practice that is an advanced primary care model. And this has nothing to do with the fact that it's for older adults or for people with dementia. These advanced primary care models in ambulatory care, the role for registered nurses has changed significantly. Most of us who went to school, even today, there are people coming out of school that have not had exposure to what ambulatory care is like for a registered nurse, what that role looks like. Or if they went to school, certainly when I did, you were never exposed to that. And it would look differently today anyway. So in my practice, this advanced primary care practice, the registered nurse is a billing provider. They're billing for different services than the nurse practitioners, but they are billing for their time. They are care coordinating. They are doing annual wellness visits, transitional care. I mean, they are actually also part of the team that drives reimbursement for your practice. And so if you're thinking, well, what I really want is I want to have relationships with patients, in my case, patients and families. I want to be on a team where I've got more autonomy. I've got some respect. People treat me like a, professional, educated clinician that I am. It may be in an ambulatory setting, especially in these advanced primary care practices. But I do generally think, and again, I don't want to deter people from going back to school. I mean, if that's really what you've always wanted to do and now's the time, by all means, go. We're glad to have you. But if you're just trying to escape where you are, the wonderful thing about nursing as a profession is you have so many possibilities, right? You only want to work with well people and focus on prevention. We got that. You want to not actually see patients in person. You want to review their charts. We got actually multiple industries that will let you do that. You want to be an entrepreneur, right? Like, do you want to start a business? And maybe your business is a software solution. Maybe it's a device solution, or maybe it's a new practice like mine, where I actually get to start a business to replicate practices. So, the opportunities are endless. You don't need to switch. You definitely don't need to switch to a different level per se. If you want to go to something different and it requires, then you go, okay, what kind of training, what kind of preparation do I need to get me there? That's a secondary question. The first question is, where do I want to go? And, but there's really, you don't need to leave the whole profession. You don't need to make a switch that doesn't build on all of this education and expertise that you already have. And in other professions where nurses are going to other professions for different careers, second careers, how fortunate for them to have someone with a nursing background who has such a unique perspective on the human condition. I mean, I don't think you'll find a better perspective if people really do say, what I've always really wanted to do is teach school. That's great. But I think, it's heartbreaking, though, when people say what I really love is bedside nursing, but I can't do this. That we need to address.
I think you've touched on so many interesting things there. And I don't think, I think many nurses, and honestly non-nurses kind of looking in, I don't think really realize that nurses can work in primary care settings or non-hospital settings, that you said.
Right.
I'll tell you right now, when it comes down to billing is one of the most under-discussed things out there. As someone who's not in nursing, people just don't talk about it. It's flabbergasting that this is like the sort of elephant in the room at any given time for any sort of clinic owner. They know they underbill, they know their billing issues, and there is no standardization or consistency done around markets or states or nationally. It is so bizarre to me. But you're absolutely right that the fact that an RN can be a billing provider, the first time I heard that was from you. Mm-hmm. And it's so interesting just to even hear that. I think as we're wrapping up, I would love for you to sort of maybe talk a little bit about the concept of choosing versus picking. That might be a great way to um, crystallize what you just said. And I'm happy to talk about it too. I just figured, your voice is more soothing than mine. Literally, that is what my team has told me in this conversation. They've slacked me and say, "Oh, Carolyn's voice is very soothing. Let her talk more." I said, "What?"
No, they got the nurse voice.
Is that a thing? A nurse voice?
No. if it is, well, maybe. I can think of when people say nurse voice, I can take that in multiple directions, probably. Like you got the nurse voice when you need to like run the code. You got your nurse voice when you need to call a provider who needs to get in here and see this patient, or you need to assert yourself. And then there probably is the nurse voice that's soothing and gentle. Depends on the day, right? But choosing versus picking, I might be stumped on this one a little bit. That's so interesting. Right. So yeah, I guess let's think about this. So when I think about sort of choosing, right, this is so much more intentional. It is, this is where I want to go, and then I'm going to build my strategy and path around it. Probably the way we accomplish lots of other things, we sort of begin with what's the end that I'm trying to get to, and how do I want to sort of selectively and intentionally make my way in that direction. That's that to me is sort of choosing, as opposed to, you've got this sort of like, these are like the 5 things I've got in front of me. I'm gonna pick something that someone else has created as my options. And so I guess that's how I sort of think about that. And again, that intention, that choosing does not have to be the end game. I know, like the Stephen Covey, like begin with the end in mind. Okay, let's just begin with the next point in mind. I was reading this quote, and it's attributed to Abraham Lincoln. I'm just going to assume that is correct. And the question was about finding an end to the Civil War. And how do you know, how did you envision the end, the way that it was going to sort of, how you wanted it to be at the very end? And his comment was, I'm not necessarily able to navigate all the way to the end. I can only navigate from point to point, which was a reference to time that he spent, I guess, as a young person navigating the Mississippi, which winds quite a bit. And so the idea that you can see the total end is not realistic, but I can see the next point ahead of me and at least just go from point to point. And I think that's how I think about this notion of, this intentional choice about where you're going in terms of your career. It's okay
I think
to go.
I'm with you. I think the concept of this 10-year, what's your 10-year vision? It's so ludicrous in my opinion. It's like, what, 10 years? 10 years from today was such a different world. We were on the iPhone 3. We didn't have 4G LTE. Crypto wasn't even in the beginning stages of anything. Telehealth was in its infancy. You didn't have anything. 10 years ago, I much prefer, and again, maybe this is my own limitations, but I much prefer to think in a 3-year sprint. I can think and visualize 3 years out. Anything more than that, you're like, I don't even remember the person I was 5 years ago, if that makes sense.
Right.
Well,
and you don't want to prematurely close yourself off to opportunities that come your way. So I think you get too fixed on these endpoints, and you're sort of like, well, no, that's where I'm headed. Let's maybe keep an open mind when things come our way, because you don't know what's going to come up. That's, through your network, through your experience, positions that didn't exist before professionally, that turns out to be exactly the fit for you, or maybe you have the opportunity to make a position for yourself in that new space.
No, you're absolutely right about that. You're absolutely right. As we're wrapping up, Carolyn, is there any lasting pieces of advice you want to leave with the community, or is there anything you want to ask of the community that is going to listen in? Can they do anything for you?
Gosh. So actually, there are a couple things. So let me just say, if there's someone listening who thinks, this new model of care is something we actually be very interested in at our institution, and you have the ability to make that kind of connection, I am looking at opening a different sites in new places, so you can contact me for that. That actually be a very welcome conversation. We like talking about that. We just recently got some quotes from our care partners because of a marketing campaign coming up, and one of them had a quote which I had the same exact quote from a grant we had applied for, which was, "I look forward to the day when this can be the model of care for people living with dementia." So, whew. So we're gonna see what we can do to move in that direction. So that's that. I think though, you know, again, I'm a reader, so I'm going to attribute this. This is a Marcus Buckingham sort of concept from a book he wrote called 9 Lies About Work. And I read it a couple years ago. I've been talking about it this week with some folks. And he talks about how sort of your life and your work life, even, if you think about that sort of as a woven piece of cloth or material, and that there are some threads that are just so bright that even though they're part of that weaving, they stand out. And he calls those your red threads. And so in your work life, if you consider what are the red threads for me, what are the things that I get to do that I don't think about I have to do, but I get to do. And then you start to then think about your intentions is really, how do I get more red thread time in my life? And I think that can apply in multiple venues, but that may be a great starting place as you're thinking about what your next options are or how you make your work or home life better today. So that's been meaningful to me. I hope it is to you.
That was incredibly well said. Carolyn, thank you so much for being on the show today.
Thank you so much for having me. This has been great fun.